We're going to shift to a slightly different disease category now. As you might expect with my interest in stroke, we're going to talk about stroke. And I think we're really fortunate here to have a great group of physicians involved in stroke already. And John Terry, who's here, Brad Jacobs, who's there, Jacob Kitchener. I hope not everybody's here because somebody's got to be taking care of patients. Rob Schneider, and our next speaker, Bryan Ludwig. I first knew Bryan when he was a resident at Vanderbilt, one of our great residents, by the way, and had stayed in touch with Bryan over the years as he went to the University of Iowa to do further training, neurointerventional training. So he's back home in Dayton, and has been really developing a great interventional program here, and really have to thank all of our support people in the stroke program as well, who've done a great job with this. Angie Black, Diane Flyman, and all of our advanced practice nurses and other folks who work in this program at multiple sites. So we have primary stroke centers at multiple sites here in town now, and this is a great thing for the community. We hope to expand those. So Bryan's going to talk to us about interventional pieces. So Bryan.
Thank you again for the opportunity. I feel like it's certainly an honor to be included in the names that are speaking today. Steve Bowman, Dr. Gaines, and Dr. McDonald, and Tim Cope, and of course Dr. Schweitzer, who we're very happy to have joining us shortly. And it's really exciting. We've been, like all of us, been waiting for this day so that we can unveil what we've been working on, and hopefully what we hope to work on in the future. So I'll be focused on, again, much like Dr. Schweitzer, some of the history as well as where we are now and where we want to be in the near future. Just take a moment. I can launch anyways without slides. But so the topic is going to be, of course, stroke, as Dr. Gaines mentioned, and it's a topic that's near and dear to my heart too, especially having Dr. Gaines as a mentor, as doing training at the University of Cincinnati in their stroke program. That got me heavily interested in this disease process. And for those who, it's right there. For those who don't deal with this as much, stroke. The definition of stroke is the, okay, it's working, great. Just go ahead and move past that. So we'll talk a little bit about what advances are coming out in neurointerventional, as well as illustrate what we're trying to grow in context of research with our colleagues at Wright State. And again, of course, aided and sponsored and heavily supported by Premier Health. So stroke, there's two types of stroke, obviously hemorrhagic stroke we've probably heard about, and of course ischemic stroke. Both disease processes are serious ones, as I'll point out here, and give you some statistics that you may or may not have heard. And the definition, as we were just covering, is a blood vessel that carries nutrients and oxygen to the brain is either blocked or ruptured, which then results in cellular death or neuronal death almost, well, very rapidly, but not instantaneously. And it can happen at various rates, which we're going to use as a tool, as you'll see in our imaging. So is every stroke the same? No. I mean, there is ischemic, which again constitutes about 80% of stroke, and then 20% is hemorrhagic. It is the fourth leading cause of death in the U.S. About 800,000 people experience a new or recurrent stroke each year. This is taken from data in 2010. Again, about $74 billion is estimated as a direct or indirect cost of stroke. So certainly heavy impact on what we talk about in fiscal responsibility in healthcare. So the concepts of what we do. I'm both a vascular neurologist and a neurointerventionalist, as are several in my group. And the neurointerventional side of things asks us to essentially open up arteries that need to be open, that are closed for a reason, or close an artery that may not need to be open, causing problems. And then the last part is injecting potentially therapeutic agents and arterial medications into the CNS, into the cerebral vascular system for various disease processes and treatment of such. So I'd like to go over a few things that we do, and again, highlight where we are, where we hope to go, and some of the new technology that is available, some already on the shelf and some soon to be. So arteriovenous malformations are a disease process that are fairly rare, estimated in sort of that 1 in 100,000 type rarity, but one that causes seizure, as we've heard so much about already. It also causes stroke and hemorrhagic stroke, as you can infer here by the slide. But what it is an arterial connection to the venous system that bypasses the capillary system, which increases the shunting and the pressure inside of this vascular abnormality, again creating a steal phenomenon, some believe, which could cause seizure, as well as hemorrhagic phenomenon, obviously causing impairment from the increased intracranial pressure and bleeding itself. So here's a picture of a young male who had a history of seizures that were treated with medicine, and then unfortunately came into our emergency room with a severe headache after lifting weights. And this is his diagnostic cerebral catheter angiography imaging. So again, imaging using wires and catheters through the arteries themselves to inject contrast dye and eliminate the arteries, the inner walls of the arteries, to give us very clear pictures. And what you're looking at is the vertebral artery on the left, and it, as it sort of works its way up into the basilar artery, I don't know if this arrow will work, but as it works its way into the basilar artery, if you look way out into the posterior cerebral artery, you see this sort of web-like tangle of vessels that is not normal, and that's exactly where his bleed was located to help us out and confirm that that is the source of the hemorrhage. And it is a smaller Spetzler-Martin type 2 arteriovenous malformation. Now this one is an entity that usually is tackled by multiple teams, and we're just one of those teams. Dr. Schweitzer and others in neurosurgery are the other part of that team, as well as vascular neurologists and of course neurocritical care. So I like to highlight that because it isn't just one procedure, and it certainly can lead to long courses in treatment that require multiple subspecialties to work together. But this is how we treat them on our end, and it's sort of stage one, if you will, to eliminate the process, or at least begin to eliminate this process. And what you're seeing on this slide is a material called Onyx. It's actually an ethylene vinyl alcohol. It's a compound that I think is best described. I got this analogy after watching my 6-year-old eat a s'more. But he had cooked the marshmallow and he squeezed it together as he bit in, and it sort of oozed out all over himself, which I got the honor of cleaning up. But this polymer, this compound, is very similar to that, where you first put your catheter about as close in proximity as you possibly can to the arteriovenous malformation. And once you've done diagnostic pictures and identified that your catheter is in the correct location, the arteriovenous malformations do not feed normal brain tissue. As they bypass the capillary system, oxygen, nutrients, and other things are not exchanged through these malformations. So the process is to block them off, and then in the second stage is usually resect or radioablate them with radiation. But so you have to be confident that you obviously are injecting into the AVM and not into normal vasculature. But this polymer, getting back to my s'more story, it hits the bloodstream, and the hydrogen bonds within this bloodstream, and it basically turns into a sort of a foam. And but the core product is actually a liquid, so that if you look at this without it actually touching any blood or water, it looks like a black oily liquid. And as soon as you drop it into a container of water, it puffs out into this foam. Now the core of it is still liquid. The only thing that's touched the outside hydrogen bonds has now foamed up. So much like the s'more, where it's kind of cooked on the outside but it's soft, sugary inside, you can actually put this into the artery and then push on it with excess onyx material, and it'll flow forward, much like lava will. Again, everything that hits the artery sort of foams up, but in the inner core, it continues to move forward. And that allows us to take on very complex arterial and venous structures and really move this material through all the connections that exist in an AVM without, in the past, we would have to do without, going back to the past, we'd have to actually go into each one of these and try to glue them off separately. And you can imagine the time it would take and the risk for the patient that would put them under. So what you see here is our efforts to get the microcatheter out into the very distal posterior cerebral artery and start injecting this material very slowly and fill the arterial side and then push it into the venous side, blocking this entity off and shooting for what we hope obviously is a cure, but most likely will be a complete or a near complete occlusion of it so that this entity can be then resected. And that, of course, decreases the bleeding risks and makes the surgery safer, and that's exactly what happened. So this patient did very well, and you know, it highlights some of the new technologies. Now, I will say the future. What is the future? And some of the companies that we've been discussing with are working on products that do not remain radiopaque, as you're seeing here on the fluoroscopy in that bottom corner. In fact, they're looking at products that degrade over time. Even though the arteries will still be occluded, you can then see through this pathology that you've now repaired. So the benefit of that would be is that if you have a large AVM, you have to go back and do multiple rounds of embolization, multiple stages, you could see through your previous work. And since we're working on two-dimensional films, that would be very helpful. Another hemorrhagic stroke cause is intracranial aneurysms. And like the AVMs, we repair those using endovascular means, wires and catheters, in conjunction with our colleagues in neurosurgery and neurocritical care. This is a patient that had a subarachnoid hemorrhage, which is where bleeding can be found if an aneurysm ruptures. It's where the arteries live. This subarachnoid hemorrhage was as a result of a aneurysm at the top of the basilar artery, at the artery summit, as we say, or the tip of the basilar. This is a picture using wires and catheters, again injecting contrast into the vasculature, showing that the aneurysm is located and wide-necked, is what we would say, meaning the origin of the aneurysm from the two parent vessels that it's arising from is about the same size as the dome of the aneurysm, which creates a problem for us because these are the schematics of what we have currently available. I'm going to update that in just a second, but this is what we had currently available to us to repair aneurysms via endovascular route. You see here that C is really the nuts and bolts. If you can get a microcatheter guided into the intraluminal portion of the aneurysm, you can then deliver detachable coils. Now, going back in the past just for a second, our Dr. Terry and I's mentor at University of Iowa was one of the pioneers at UCLA of endovascular techniques, and he would tell fairly fascinating stories about how coils came about because they are detachable. And oftentimes the early coils were made so that you had to pass current through the coil itself, and it would break a filament, then thus detaching the coil from the wire that you used to push it into the aneurysm. And a lot of the coils are still made that way, although many of them are mechanical now to eliminate the need for multiple attempts to break that filament. But he would tell these interesting stories about hooking up car batteries and waiting for 2 hours to see if the filament would break. And thankfully, we've moved far, far from that technology where the detachment of coils and repair of these aneurysms can be under an hour if done very quickly and in the right location. So it really has come light years, and that was only 20 years or 25 years ago that they were doing that. So, so these are the current mechanisms: balloons, stents to try to keep your coils happy, meaning inside the aneurysm and not inside the parent artery. And here's a demonstration of that same aneurysm with the arrows pointing out where the stents are. This aneurysm, because it was wide-necked, had to be stented in what we would call a Y-stent configuration. It's just the shape of the letter Y, as you can see. And here it is again with repair. So that highlights that the stents keep the coils where they're supposed to be, and the coils are then occluding the aneurysm so that it doesn't receive any blood supply, eventually thromboses itself off, sclerosis down into fibrous scar tissue, and in theory shouldn't bleed again. So all that said and done, that's a lot of work, and it's a significant amount of risk for the patient. So individuals have said, how do we do this better? And one particular solution was, could we use stents that are flow diverters? So let's get rid of the need for coils or entering into the aneurysm altogether, and maybe we could put some sort of more covered stent across the neck of the aneurysm and eliminate that whole second step of coiling. And this is one device called a pipeline, and it is a woven mesh stent. It has about 30% more coverage than a normal stent that I just showed you in the previous repair. And this pipeline is now available. We've used it 4 times so far, and it's really designed for a very specific section of the anatomy. You cannot, at least in the early on-label phases, you can't use it in other places other than the internal carotid artery. But it is a fascinating technology because seen here in animal models where you see the aneurysm sort of cross-sectionally, thrombus has now occurred because of the slowed flow within that pocket. And even more interestingly is that the concern for putting this across other arteries that may exist in the proximity or near proximity to your aneurysm was certainly raised in the upfront. And what they showed was that endothelialization does not occur when you put this woven stent over the parent or over a branch point vessel. And that's shown in that microscopy, electron microscopy slide there, and below, that the artery is still patent, although you see complete endothelialization of the rest of the stent. So this has been used all over the world. In fact, South America and Europe lead us by a few years on its use, and they've been using it in multiple different territories, vascular territories intracranially. We are using it in the internal carotid artery, as shown here, as case done by my partner, Dr. Terry. This particular aneurysm was of size and location that it was appropriate for this device, and I think you'll notice that the results are pretty striking. Again, it cuts down the time for the procedure by about 2 hours, or 2 to 3 hours in this particular aneurysm, and it also allows for you not to enter into the aneurysm, which obviously is a high-risk point. When putting your microcatheter and microwire inside the aneurysm, rupture is always a concern. So changing gears to the ischemic side of things. I don't have time to obviously cover all of the ischemic details, but I thought I'd highlight a few things that we're doing differently nowadays. And one thing is the imaging of acute ischemic stroke, and we're going to talk a little bit about that in various methods here, but the CT scan was something that was always, it still is a huge part of the initial evaluation. And the standard CT scan with 5 millimeter slice cuts, and you look at the brain tissue, and in theory, if it's an ischemic stroke, CT does not highlight early ischemic stroke changes. Even within the first 6 to 8 hours, it'll look as normal brain tissue would. But oftentimes we can see densities in the arteries that help us identify someone who might have an artery blocked before we even get better imaging to look at these vessels. Well, a group in Germany just published their data, Wright et al. In Stroke in June, I believe, in June of this year, published data, and they actually came and talked to us about maybe considering decreasing the thickness of your head CT slices to further look at vessels. And what I'd like to do here is just kind of flip through just a few of these on a head CT of a patient that is having an ischemic stroke in the right middle cerebral artery. So that artery appears on your left, even though that is the right hemisphere. And I would point out the 5mm slice, it's very difficult to see any kind of bright signal, and clot is bright on CT. And the circle there guides your eyes to where the artery lives. And I think if you move right over to the other side where it's a 1.25mm slice, just by taking thinner slices, and this doesn't subject the person to any difference in the CT scan, this is all post-processing, so the same radiation dose, same time. We, I think, highlight very clearly that the thinner slice shows that there is a very bright signal in that artery, and that suggests that there's a clot. Now, this research team also went on and used data suggesting that clots greater than 8mm in length typically do not respond to IV TPA, or one of the medications we use to break up clot. And this gives us a very unique tool that we can use quickly in the first initial evaluation of patients to get a sense if they're going to respond to our initial medical therapy and then maybe have to go on to surgical interventional therapy. So it's kind of a novel use of the CT, which really has been there all the time underneath our noses, but it's really added nice data to our workup. And also, I wanted to highlight what we can do in the new angiography suite. We have a brand new suite that was built in October of 2011, and it has pretty much the latest in medical imaging angiography technology. And I thought it was really highlighted well in this case where we repaired a carotid artery in a patient that had a stroke that was downstream from this narrowing, which is in the neck. And I don't know if there's no circle here, but I'm hoping your eyes get directed to this particular area of the artery, which narrows significantly and has thrown likely embolic debris into the upstream portion of this artery, causing a stroke. We repaired this with stent and had very nice results, but when we went further and looked at the angiography transit time. So this is part of what our technology can do now with the new suite. And what you're looking at is the before and after pictures, before the carotid stenting and after the carotid stenting, in intervals that are identical, which are time. So 1.5 units of time compared to 5 down in the blue, and it's color coordinating this. And it's a little difficult to interpret, so I will try to walk you through this, but the nuts and bolts of this is that this is looking at how fast contrast is moving through these arteries and into the system. And you would expect that the contrast would be seen early, obviously, since the catheter is down here just below the screen, and that this contrast would then move and over some period of time and then get out into the distal portions of the arteries and then move through the capillaries and into the venous system. And on the before picture, what we see using the exact same injector, exact same catheter, exact same location, so trying to keep everything pretty standardized, is that it took the blood about 5.6 units of time, which is a fractions of a second, to get into the distal arterial phase. But if you look over the after section, at the 5.6 second time interval, you see the venous structures well highlighted. So we actually did the subtraction of this, and the blood was transiting through this particular gentleman's brain at 1.2 seconds faster than it was before the carotid stenting. And that makes a big difference. Transit time's been shown to be an indicator of ischemic stroke and a risk factor for it if your transit time's not normal. So I thought it was just interesting. It's one of the few little tricks we can do now looking for ischemic stroke and treating these types of patients in our angiography suite. So sticking on that theme, what can we do to evaluate patients in trouble with stroke? MRI is one thing we're using heavily in our initial stroke workup. Okay, all right. So patients undergo MRI acutely that are having symptoms deemed that are severe enough that may warrant potential surgery, such as cleaning out the arteries. And these images show MRI sequencing showing stroke as white on your left, and the perfusion, which is color mapping of how well the blood is transiting, much like we just talked about in the angiography pictures. The MRI can do that as well, and it shows you that in a color map that it's taking a significant amount of time to move the blood through the right hemisphere compared to the left hemisphere, and that there's only small amounts of stroke that have actually developed in the right hemisphere, suggesting that there's a severe mismatch of actually permanent damage or core damage, core ischemia to this tissue compared to the penumbra or tissue to be salvaged. So this would be a person that would be a good candidate for revascularization and trying to break up the clot, either using medical or most likely thrombectomy devices. So here's that sort of mismatch again. So these are the candidates we're looking for. At the same time, we use the MRI scanner to look at their arteries. And this is just sort of a picture looking down inside the head. And I think you can notice the asymmetry here on the right, again, where you saw that the stroke was occurring and that the area of tissue that was in big trouble was also occurring. Well, the artery is no longer seen there either. So now you've got multiple things to confirm this person's in trouble. So what do you do? At this stage, if IVTPA has not worked, we move to mechanical thrombectomy. These are the devices we've used in the past. The top one is an aspiration catheter. The bottom one is a retrievable thrombectomy device where it's sort of a corkscrew. It's called a Mercy retriever. Both of these are sort of older technology that we use if the newer technology doesn't work. And this is the newer technology, which is retrievable stents. The idea, obviously, is to put the stent across the thrombus that's blocking the artery, allow the stent to intertwine or intercalate into the thrombus itself, and then these various stents have various ways of collapsing, and as you bring them back into the catheter, they ensnare the offending agent, the thrombus, and bring it out of the body, usually under either aspiration or occlusion, balloon occlusion, which you see here in this picture. There are already 3 devices, I believe, on the market doing this, and we've been using these since May with excellent success. This is one of the cases where the right middle cerebral artery was blocked, and you see it in both lateral and anterior and posterior views. And here's the result after the stent was deployed and retracted with ensnaring the clot. I think you can see that it's pretty dramatic that the repairs we've seen have been in the same statistics echoed in Europe, which are about 70% success rates when we go after these types of cases. That means 70% success in recanalization, which there are plenty of studies, actually one we're involved with, trying to look at the outcomes and how much this significantly improves patient outcomes. So again, in the spirit of talking about both clinical and research, we need to focus on the local collaboration fostering neuroscience to translational research. And these are the clinical trials that we're involved with. I don't necessarily think we need to go through all these, but they involve mostly stroke and one aneurysm trial looking at the different coils used for repair of aneurysm. And then our own projects that we're moving through, and I think, like Dr. Schweitzer, we're excited about the collaboration with Wright State. We've been already in discussions with colleagues in the engineering department looking at aneurysm specifically with computational fluid dynamics and attempting to create models that may be able to predict which aneurysms may go on to rupture, which is very exciting and really wouldn't be able to be done without this kind of collaboration. That kind of technology is not easy to come by. And also we have had very nice interactions with friends of ours at Mound Laser and Photonics Center exploring potential partnerships in private technology with their group, looking at how we can marry clinical and some of the manufacturing that's done right here in Dayton, which is also surprising and interesting and exciting collaboration. So that is I think I went over a little bit, but that is the end of my time. Is there any questions?
How frequent is it to rupture an aneurysm while in it?
It actually happens it happens in less than 1% of the cases. That's our own internal data collected from our database. Across the country, that's mirrored. It's less than 1%. The cure, if you end up putting a coil through the dome of the aneurysm, the cure for that is coil faster. As I always say, I mean that's really the treatment. Right. I mean, really the idea is to get the artery blocked. Now, some other mechanisms are putting up a balloon across the aneurysm neck. Some people favor using balloon technology to cover the neck of the aneurysm, even if it's deflated the whole time you're working, so that if something like that were to occur, you could quickly inflate the balloon, stop bleeding, but you run the risk of obviously occluding the vessel at the same time. So it does happen in less than 1% of the cases, but it's reality we have to
Because you
face.
said you were just detaching coils with an electrical discharge, and therefore I would think you wouldn't have as much control over them.
Well, you don't detach them unless you know exactly where they are is kind of the key to that. But you're right, once they're detached, you no longer have control, and if one doesn't do what you like it to do, then you have to snare it. We have micro snares and all sorts of tools to try to get in there and remove it. We have to use those in extremely rare situations. They collect dust on our shelves, thankfully. Any other questions? Thank you again.